Good evening, all, and welcome to yet another Rare Info Series webinar by Organization for Rare Diseases India, that is ORDI. I am Dr. Kshitija, Consultant Clinical Geneticist at Apollo Hospitals, Navi, Mumbai. Today, we are going to bring to you yet another rare disorder where the patients have fragile bones but an unbreakable spirit. Our speaker for today is Dr. Prajnya Ranganath. Madam holds a DM in medical genetics from SGPGI Lucknow. She has over 100 peer-reviewed papers and 23 plus book chapters. She has also edited a book titled Genetics Update for Next Generation Clinicians. Also, Madam is a member of Technical Expert Committee on Biomedical Sciences of DBT, Government of India, and also of DBT Umeed program. She is a member of National Expert Group of groups of ICMR Rare Disease Consortium. Also, Madam is a member of ICMR's Project Selection Committee for Genetics-related research projects. Madam is an executive committee member of AIIMS, that is the Society for Indian Academy of Medical Genetics, and also an editor of their journal, Genetic Clinics. Madam has special interest in genetics of neuromuscular disorders and also skeletal dysplasias. And today she is going to talk of enlighten us about one such skeletal disorder, that is osteogenesis imperfecta. The topic for today is clinical manifestations and management of osteogenesis imperfecta. So without any delay, let me hand over the stage to Dr. Prajnya, ma'am.
Thank you so much, Dr. Kshitija, for that kind introduction. And at the outset, I'd also like to thank ORDI and Mr. Prasanna in particular for this opportunity. So I'm really very happy to be here as a part of this series, this initiative which has been taken up by ORDI. And I'll be talking about the clinical manifestations and the management of osteogenesis imperfecta. So, are my slides visible?
Yes, ma'am.
Right. So, as we all know, OI is a genetic disorder which is characterized by reduced bone density and increased risk of fractures. And most types of OI are caused by either an abnormality in the synthesis or processing of type 1 collagen. It has also been referred to as brittle bone disease. So, if you look at the pathogenesis of OI, basically, we know that several genes are involved in collagen biosynthesis and also in the maintenance of bone homeostasis through regulation of osteoblast differentiation of function. All the genes are listed here, at least most of the genes which are known to be associated with these processes. And variants in these genes are known to cause various different forms of osteogenesis imperfecta. So if we look at this nosology of genetic skeletal disorders, the 2023 version, about 55 all these disorders which are associated with bone fragility are listed under group 26. And here there are some 55 disorders listed in group 26, out of which around 22 types of osteogenesis imperfecta are known. So the different types of OI are mainly classified based on the molecular basis of these conditions. And initially, it was believed that OI is an autosomal dominant condition because the initial two genes which were known to be associated with OI were identified, were COL1A1 and COL1A2. And variants in these genes follow mostly an autosomal dominant pattern of inheritance. But over the years, particularly with the available of next generation sequencing technologies and so on, it is now known that several different autosomal recessive types of OI are also there, caused by variants in many genes other than COL1A1 and COL1A2. So these are all the different conditions which are listed in group 26 of the nosology. And as I said, there are 22 types of osteogenesis imperfecta which are known currently. So the classical forms, the ones which are caused by COL1A1 and COL1A2, of course, have an autosomal dominant pattern of inheritance. And the type 5 and type 9 also have an autosomal dominant pattern of inheritance. Whereas most of the others, type 6, type 7, type 8, in fact, type 9, which is caused by variants in PPIB gene, can be because of heterozygous as well as biallelic variants, and therefore can have a dominant as well as recessive pattern of inheritance. Similarly, type 10, type 11, and so on, all the way to type 22, most of them have an autosomal recessive pattern of inheritance. There's only one exception known so far, and that is the MBTPS2 gene related type 19 OI, which is known to have an X-linked recessive pattern of inheritance. So the classification which was initially proposed in 1979 by Silence is based on the severity of clinical features. And in fact, this conventional classification is still followed, at least for clinical purposes, because it helps us to assess the severity of manifestations in the patient and design our management plans accordingly. So, type 1, as per this original conventional classification, refers to the classic non deforming type of OI with blue sclerae. So, here fractures are usually few. The sclerae may be blue or gray in color. Dentinogenesis imperfecta may or may not be there. Bone deformity is either absent or it may be mild, and short stature may be present but is not always necessarily there. Hearing loss is often seen in adulthood. Whereas the type 2 is the most severe type, which is also referred to as the perinatal lethal type. Now, here there is antenatal onset. You tend to see these multiple rib fractures, minimal calvareal mineralization, platyspondyle, marked compression of long bones, as you can see in the X-ray of a fetus, affected fetus over here. Dark blue sclera is usually there, severe bone deformity, and short long bones. There will be small thorax with lung hypoplasia also, and many of these cases are perinatally lethal. Fetal hydrops may also occur. The type 3 is the progressive deforming type, where there are multiple fractures, severe bone deformity, severe short stature. And as you can see, unless they are treated in a timely manner, they have a lot of deformity, and most of them are wheelchair bound or bed bound. And here again, the ribs will be thin, platyspondyle will be there, the bones will be thin and gracile, and popcorn epiphysis may be seen. Sclerae are usually blue, and dentinogenesis imperfecta may or may not be there. Hearing loss may be there. Some of these conditions may have an antenatal onset of fractures also. And then the type 4 type, which is called common variable type, where the sclerae are usually normal. They'll also usually have multiple fractures. The bone deformity may be mild to moderate, not as severe as what you get in type 2 and type 3. Short stature again can be variable. Sclerae can be normal or gray in color. Dentinogenesis imperfecta may or may not be there. Hearing loss again may be there. So next, once we have done the thorough clinical evaluation and once we have a suspicion of osteogenesis imperfecta, we have to move on to the molecular genetic testing. So why is it important to do the genetic testing? For the patient, of course, it helps us in identifying the exact etiology, and the precise diagnosis helps us in accurate prognostication and appropriate management. Whereas when it comes to the family, it helps us provide accurate genetic counseling. It helps us in identification of the exact pattern of inheritance and risk of recurrence in the family. Also, for the most severe types, they may not wish to have another child affected with the same condition. And based on the exact genetic basis identified, you can give them the options of prenatal or pre-implantation genetic testing to prevent the recurrence. Also, for other family members, you can offer carrier testing to determine the risk of recurrence in their offspring. So, for all these reasons, it is essential to do genetic testing, even if you are clinically fairly sure that you are dealing with a patient with osteogenesis imperfecta. Now, what is the choice of testing? So, normally we know there are different kinds of genetic disorders. You have the gross chromosomal anomalies, you have the chromosomal microdeletions and microduplications, and then you have the monogenic disorders, which are caused by mutations within individual single genes. Now, most of your, and or rather all of your osteogenesis imperfecta cases are monogenic disorders. They are caused by mutations in individual genes. These could be either single nucleotide variants or insertions or deletions of a few nucleotides, or it could even be exon level deletions or duplications. And again, depending upon the nature of the genetic disorder that you're suspecting, normally you go for the, accordingly, you choose the genetic testing. So if you're dealing with a chromosomal disorder, you go for a cytogenetic test. If you're dealing with a microdeletion or microduplication, you go with molecular cytogenetic test. If you're dealing with monogenic disorders, you go with molecular genetic test. So here, because OI is a a monogenic disorder, for suspected cases of OI, you'll be going for the molecular genetic tests. Again, what are the different molecular genetic tests which are available? There are several. These three are, of course, the ones which are most commonly used. There are many more, but amongst the commonly used molecular genetic tests, you have Sanger sequencing, multiplex ligation dependent probe amplification, and next generation sequencing. Sanger sequencing is the conventional method where you do PCR amplification of individual parts of the gene, and then each of these individual amplified parts, which we call amplicons, are sequenced. So usually to begin with, you sequence all the coding portions, that is the exons, and the flanking intron-exon junctions, because that's where the splice site variants will lie. The majority of the mutations, usually 95 to 98% in most cases, lie within the coding regions of the genes or at the splice sites. So once you have sequenced all these sites and you compare the sequences of the patient to the reference sequence, you identify where the variant lies. So that's what a Sanger sequencer looks like. It's basically a capillary sequencer. And this is what the sequence chromatogram would look like. In fact, the variant that I've highlighted here is a heterozygous pathogenic variant in the IF5T-M5 gene, which is the most common variant known to be associated with type 5 osteogenesis imperfecta. Almost all the cases of type 5 OI, which have been reported to date, except a few, are known to have a heterozygous pathogenic variant in this particular position. So Sanger sequencing is suitable for sequencing of small single genes. Sequencing to look for known specific disease-causing variants. I gave you the example of the IF80N5 variant. Then validation of variants identified through NGS. And also, when you want to do targeted variant analysis of family members of the proband, which is called familial variant segregation analysis. You don't need to do exome for all of them. Once you've identified the variant in the proband, that is the index case, that particular variant can be tested in all the other family members through targeted Sanger sequencing. Moving on to next generation sequencing, we know that this is a massively parallel sequencing strategy. Different chemistries are available. The common chemistries which are used are the Illumina sequencing technology and the ion torrent sequencing. So here, large genomic portions can be sequenced at much lower cost and much lesser time than Sanger sequencing. So there are various NGS-based testing approaches which are available. You have the multi-gene panel testing, which involves a simultaneous sequencing of multiple genes associated with a specific phenotype. Example, you have the OI panel, you have the skeletal dysplasia panel, and so on. Then you have something called clinical exome or focused exome or Mendeliome sequencing, where you're sequencing coding portions of all the genes associated with known disease phenotypes, which are listed in OMIM. Then you have whole exome sequencing, which involves sequencing of the exons of all the genes and also the flanking intron-exon junctions. That is the entire coding portion of the genome. And then you have whole genome sequencing, which involves sequencing of the entire genome. So typically for most of these skeletal dysplasias, which have overlapping phenotypes and also the osteogenesis imperfecta cases, most of them have overlapping phenotypes. Clinically, it is difficult to pinpoint exactly which gene it might be. Or sometimes you may want to look at maybe, let's say, only COL1A1 and COL1A2, but the genes are very large. They are like multiple exons. So doing Sanger sequencing for such large genes, multiple genes will be very, very time consuming and expensive. So there you go for these next generation sequencing based technologies. Most often nowadays, we go for whole exome sequencing and we tell the lab that this is the phenotype. These are the specific conditions that we are looking at so that the lab can first analyze the relevant genes related to the phenotype that we have given the lab and or the specific differentials that we have told the lab. And if the lab is not able to find variants in any of the genes related to that specific condition or phenotype, they can also look at genes related to other conditions which have overlapping phenotypes. So the multidisciplinary management is what is followed for OI. So here we have to have inputs from the different specialities. So you want to involve the orthopedics surgeon, of course, and rehabilitation medicine. And the clinical geneticist has to be involved, the pediatrician in the case of adults, adult medicine person, the dental person, ENT person, and so on, because there are so many different manifestations that need to be individually addressed. So typically for orthopedic therapy, lightweight and short casts are used. Physiotherapy should be started as soon as the cast is removed. Intramedullary rod placement is often done to facilitate anatomic positioning of limbs to reduce the curvature, as you can see here. So this is the curvature in the bone before the intramedullary rod placement. And here, after the intramedullary rod placement, it has become more or less straight. Bracing has to be done to support the progressively deforming limbs, orthotic support to support the joints, and pain management with suitable analgesics may be required, especially when there is a acute fracture. Pharmacologic therapy, you can use oral or intravenous bisphosphonates. Currently, these are the most effective treatment modalities which are available. So you have in the oral formulations, alendronate, residronate, and others, whereas in the IV formulations, you have zoledronic acid and pamidronate and others. So the most commonly used ones are either IV pamidronate or IV zoledronic acid or oral alendronate or oral residronate. So bisphosphonate therapies, how do they work? So they act by inactivating osteoclasts and inhibiting bone resorption. They do not, of course, alter the underlying molecular pathology in OI. So what they do is they help in an indirect fashion by increasing the bone mineral density and thereby reducing the fracture rates. Okay, just the way you use it for osteoporosis. So pamidronate infusion has been around for the longest period. So first, the bisphosphonate, this was the first bisphosphonate to be tried for OI. So maximum number of studies are available for pamidronate infusions indicated for severe forms of OI, young children usually up to 6 years of age, and individuals who cannot sit upright following oral therapy. So pamidronate infusion, you start with intravenous infusions, 1 milligram per kg per day, slow infusions uh, in normal saline over 4 hours for 3 days, once in 3 months. And it does have some limitations and adverse effects. You require repeated admissions once in 3 months, and each time the admission has to be for 3 days. It is intravenous and therefore somewhat invasive. It can have some immediate side effects like flu like syndrome, hypocalcemia. In fact, some papers recommend giving intravenous 10% calcium gluconate also after the infusion as a prophylactic measure. Long term side effects include delayed bone healing, drug induced osteopetrosis, and likely side effects. Other likely side effects include atypical fracture of the femur and osteonecrosis of the jaw. The other bisphosphonate, which is being used, and now in fact many centers have switched over to zoledronic acid infusions uh, because this there is an ease of administration here. It needs to be given only as an intravenous infusion over 1 hour on one day alone, and it can be given only once in 6 months. So it has sufficient cumulative action. And the advantages, of course, the duration of infusion is shorter, the frequency of infusions is shorter. Also, safety has been established in the pediatric population as young as 6 months. Side effects, of course, are there, but they're easily manageable. The side effects include hypophosphatemia, hypocalcemia, and acute reactions. Hypothermia can also be there. So, quite often, when we are giving zoledronic acid infusions, we start with a pre-infusion paracetamol and a infusion paracetamol, and then uh, So oral alendronate is the oral option which is available. It's usually given for older children and adults, and also for the mild to moderately severe forms of OI. There are some specific dosage instructions for this. It can be given as a daily dose also, but once a week is more convenient. So you can give 1 to 2 milligram per kilogram every week, and you can keep fixed days. So usually we tell the patients that you can keep it as every Sunday because it's easy to remember and they need to take it every once a week like this on a fixed day. So it needs to be taken on an empty stomach, whole with a full glass of water at least 30 minutes before any food, beverage, or any other medication. The patient needs to sit upright for at least 30 minutes after taking the drug. So the severe forms of OI, where they're unable to sit upright again, this might not be a suitable option. Side effects again include hypophosphatemia, hypocalcemia, and GI symptoms. So when we are giving bisphosphonate therapies, we have to do some workup prior to initiation of therapy and also during the therapy. So prior to initiation, that is a baseline, we do serum calcium, phosphorus, alkaline phosphatase, and this is repeated every once in 3 months. Then electrolytes, creatinine, and SGPT again should be done baseline and once every 6 months. And ultrasound KUB and bone mineral density by the DEXA scan should be done baseline and once a year thereafter. And while you are giving bisphosphonate therapy, the child or the individual also requires additional supplements. So oral calcium is usually given as per the recommended daily allowance, as also oral vitamin D. And in case of zoletronic acid, we give additional supplementation with oral phosphorus also. Now, these are some of the newer therapeutic strategies. For some of them, clinical trials are ongoing. For some, only preclinical studies have been done. There have been some promising results with each of these therapies, but as of now, they are not being very commonly used as a standard of care for OI. So, this includes teriparatide, which is a human recombinant parathyroid hormone, denosumab, which is a monoclonal antibody rank ligand. This has been particularly used for OI type 6 patients because OI type 6 somehow they do not show very good response to bisphosphonate therapy. Some studies have been done and they have found good results with denosumab. Also, certain monoclonal antibodies, such as the anti-sclerostin antibody, has been used, which has been found to increase the osteoblast activity acting through the Wnt-p-catenin pathway. Again, this has been tried in some preclinical studies. Also, the anti-TGF beta antibody has been tried. And there are some studies now where they have done prenatal or postnatal transplantation of mesenchymal stem cells. And some clinical studies are also ongoing. And this has been found to improve the patient's mobility and significantly reduce the fracture incidence. But again, this is not being very commonly practiced. So with that, I'll now move on to a few illustrative clinical scenarios. So in our center, we have close to around 40 to 50 patients of osteogenesis imperfecta on regular follow-up. The moderate to severe forms of OI, patients with these forms are receiving bisphosphonate therapies, either the oral form or the intravenous form. Most of them are responding well and they are on regular follow-up. There's a significant improvement in the quality of life that we notice. Although the Cochrane reviews say that there is, of course, the Cochrane review data is available from, I think, 2017. After that, I don't think there have been any further Cochrane reviews. But then, as per that, more data is required to definitively say that this would be beneficial in improving the final adult height as well as significantly reducing the risk of fractures. But then, as far as our clinical experience goes, we have seen that bisphosphonates really help and they really make a difference to these patients. Now, I'll just show you three illustrative clinical scenarios. So here we had this 5-year-old girl child who was born to 4th-degree consanguineous parents. She presented with recurrent history of fractures of the right thigh since 1 year of age. There was no history of fractures elsewhere, no teeth abnormalities or hearing difficulty. Her developmental milestones, there was a motor delay due to recurrent fractures, but other milestones were normal. And there was no family history of similar illness. So this is the child at 5 years of age, where she had a height at around minus 4.3 standard deviations below mean. and sclerae were normal, dentition was normal. The right thigh, as you can appreciate in this photograph, showed anterior bowing with shortening of the right lower limb. And systemic examination, no other abnormality was detected. So the possibilities considered here were isolated anomaly of fibrous dysplasia of the right femur or osteogenesis imperfecta. In fact, she had been referred to us as an isolated anomaly of the right femur, but because we thought although the fractures were limited to the right femur only at the time of presentation, we thought that we should consider the possibility of a generalized involvement, particularly osteogenesis imperfecta, and we evaluated her accordingly. So the skeletal survey was done, and that showed the right femur upper one-third shaft fracture with non-union. There was, however, also generalized osteopenia noted, and the ribs were slender. There was evidence of vertebral compression. There were no other fractures, however, and the bone mineral density DEXA scan showed a T-score of minus 3.5. The renal function test should always be done to rule out renal osteodystrophy, so those were normal. And the calcium, phosphorus, alkaline phosphatase levels are also normal. So, as I said, although the child was referred with a clinical suspicion of a right femur isolated anomaly, but actually the investigations were definitely in favor of a generalized involvement, that is osteogenesis imperfecta. And with this background, the child was subjected to genetic evaluation and whole exome sequencing was done. And we found a homozygous likely pathogenic variant in the P3H1 gene, which is known to be associated with osteogenesis imperfecta type 8. So now, after the molecular genetic testing, we are sure of the diagnosis and accordingly, we can now initiate the appropriate therapy. So she was started on IV pamidronate and this was at 5 years of age at the time of diagnosis. And over the next 1 year, there were no fractures observed. There was a significant improvement in the quality of her life. She started walking without support for long distances. However, 2 years after starting therapy, she had a setback. There was a fracture of the right femur after a fall, following which she underwent internal fixation rod placement, as you can see here in the photographs of the right femur at 7 years of age. And thereafter, again, she was doing well. At 10 years of age, she was switched over to oral alendronate. There were no fractures. And now she's under regular follow-up of medical genetics and orthopedics. She's doing well. Her height is at present around minus 3 standard deviations below mean. But now she's about 13 years old. She's doing well. She's attained Menarche. She's doing well in school. And she doesn't have any significant gait abnormality. So these are the video images of the child where you can see after the management with the bisphosphonate therapy and rod placement, she's able to walk nicely without any significant gait problems. So bisphosphonate therapy definitely helps, but of course, orthopedic support is essential. And together they help in significantly improving the quality of life, reducing the bone pain, increasing the bone mineral density, reducing the risk of compression fractures, and also improving the final height. Family 2, this was a non-consanguineous couple referred for preconception genetic counseling. The first child is 5 years old. She presented with issues of bending of lower limbs since birth. There was no history of fractures in this child. She had attained independent walking at 4 years of age. There was history of delayed dentition and premature loss of primary teeth. And there was also history of termination of the second pregnancy in view of short and bent femur and tibia bilaterally with fracture of the femur. On examination of this proband, we found that their height was about minus 2.7 standard deviations below the mean height. The weight was also around minus 2 standard deviations. Head circumference was normal. Bending of both femur and tibia were noted. Systemic examination was normal. These are her x-rays, which show bending of the femur and the tibia. And when we did, although there was no initial, in the initial history, the parents actually did not give any sort of history regarding involvement of any similar complaints in either themselves or other family members. But on examination, we noted that the father did have short stature. His height was 148 centimeters, and he also had dentinogenesis imperfecta. And then on further questioning, it came to light that he had history of one episode of fracture in childhood. So, based on all of this, a whole exome sequencing was done for the proband, and she was found to have a heterozygous known pathogenic variant in the COL1A2 gene, which is associated with the autosomal dominant COL1A2 gene related osteogenesis imperfecta. And targeted variant testing of the parents through Sanger sequencing revealed that the father also had the same heterozygous variant. So we should remember that OI, especially the autosomal dominant forms, which are caused by variants in COL1A1 and COL1A2, can have a significant amount of variable expressivity. The same pathogenic variant in the same family, fact that history and examination of family members is absolutely essential whenever you're dealing with a child with OI, and also, of course, for many other genetic disorders. And genetic counseling issues are always there whenever you're dealing with such cases where there is a lot of variable expressivity, because in this particular family now, if they come to us for prenatal testing for the next pregnancy, we know that being an autosomal dominant condition, and because the father is heterozygous for this variant, there is a 50% chance that each offspring will also get the same heterozygous pathogenic variant. However, the postnatal and although you can do prenatal testing and identify whether the fetus has the variant or not, whether the fetus is affected or not, it is not really possible to give a very accurate prediction of the postnatal phenotype, because the child may have only mild manifestations like the father, the child may have moderate to severe manifestations like the first offspring, or may have a more severe manifestation like the second offspring. So, this kind of variable expressivity always makes it very difficult to do appropriate genetic counseling and sort of predict the exact phenotype of an affected fetus. So, all these things have to be explained to such families in proper detail. And beyond that, it is their decision whether they wish to opt for prenatal testing or not. And particularly in the case of OI, we do know that postnatal management options are available. If started early, we can prevent deformity and fractures. And therefore, termination of the pregnancy may not always be necessary. Now, the final family. So, this was actually a consanguineous family. So, this was a 4-year-old female child, third offspring of third-degree consanguineous parents. She had history of multiple fractures, and also there was history of visual deficits of both the eyes since birth. And she had attained the ability to stand with support by 3 years of age, but she had never been able to walk even with support. There was no history of hearing loss or other focal neurological deficits or any other systemic symptoms, and her anthropometric measurements, the height was relatively well preserved. It was at the fifth centile. The weight was at -2 to -3 standard deviations. Head circumference was very less. It was about -4 standard deviations. And on general examination and head to foot examination and complete systemic evaluation, she was found to have bilateral microcornea also with corneal opacities in both the eyes. Microcephaly was there, ophthalmos was there. There were mildly low set ears, bulbous tip of nose, and bowing of both thighs and legs. And when we examined the uncle and the aunt and the sibling, because there was history of similar involvement in other family members also, we found that they had similar features, but again there was some variability. The uncle had short stature, and some bending of the bones, but he did not really have history of fractures. The aunt also had microcephaly, but normal height, and she had microphthalmia with corneal opacification, but no obvious skeletal deformity. Whereas the sibling of the proband had short stature, microcephaly, similar eye findings as the proband, with no skeletal deformities and no history of fractures. So here again, we are finding a family where there is a great deal of variability in the phenotype. And these are the images of these individuals. So this is the maternal uncle, this is the maternal aunt, and this is the proband, and this is her sibling. So you can appreciate all of them have significant osteopenia and bending of bones and bone deformities. So here now, when we did whole exome sequencing for the proband, we found that she had a homozygous likely pathogenic variant in the LRP5 gene, And the same variant was found to be present in homozygous form in the other affected family members, that is the uncle, aunt, and the sibling. And this was done through targeted Sanger sequencing. So here now we have a diagnosis of LRP5 gene related osteoporosis pseudoglioma syndrome. So they were counseled accordingly. And here again, there are studies which have shown that even for osteoporosis pseudoglioma syndrome, bisphosphonate therapy does help the skeletal manifestations. For the eye manifestations, of course, there is no specific therapy as such. So all of them were started on bisphosphonates, and the uncle and the aunt were started on oral bisphosphonates, and the proband and her sister were started on IV pamidronate, and they were followed up, and they showed significant clinical improvement. The child attained the ability to walk, and the affected uncle also showed significant clinical improvement with cessation of pain, ability to stand by himself without support, and walk with a stick. And in fact, we have published the report of this family in Indian Pediatrics. So we need to remember that not all conditions with bone fragility are osteogenesis imperfecta, and accurate genetic diagnosis is absolutely essential for appropriate management and accurate counseling. And like to thank the Department of Orthopedics and Neurosurgery for all their inputs in the management of all these patients, and also the TPT grants under the mission program on pediatric rare genetic disorders, under which we have done molecular genetic testing for some of these families. And of course, big thank you to all the patients and their families. I'll stop here. I'll be happy to take questions. Sorry about the technical glitches.
No issues, ma'am. Thank you so much for this insightful talk, ma'am. We are now open to take questions. The participants can put their questions in the Q&A section. Meanwhile, ma'am, I have a question for you, ma'am. In your experience, ma'am, have you come across any long-term side effects of these bisphosphonates, like some osteonecrosis or something like that, ma'am?
Yeah. So actually, not in our cohort. So as I was saying, most of our patients are doing well on bisphosphonate therapy. They are under regular follow-up for several years now. Some of them show some suboptimal response. Despite being on bisphosphonates, they do have fractures on and off, especially following some trivial trauma. But as such, we have not seen any of these reported side effects like osteonecrosis of the jaw and all. We do get hypothermia, that is fever, during or immediately after the infusions, the zoledronic acid infusions. So for that reason, as I was mentioning, generally we give them this prophylactic paracetamol pre-infusion, post-infusion for at least a day. We had a patient, again, we had reported that case in Indian Pediatrics with type 5 osteogenesis imperfecta, where, as we know, there is an increased callus formation as such with type 5 OI. And in that particular patient, following this bisphosphonate therapy with oral alendronate, there was a very significant worsening of the callus formation, and we discontinued the therapy and followed up this patient over the next 6 months, and the callus actually reduced. So that was one sort of side effect that we did see, long-term side effect of bisphosphonate therapy. But other than the acute fever and all that we generally get, we haven't seen any other very significant side effects. And of course, since hypocalcemia, hypophosphatemia are known, we keep these patients on regular maintenance therapy with calcium, phosphorus, and vitamin D.
Okay, ma'am. And ma'am, regarding those newer therapies like the anti-sclerostin monoclonal antibodies or anything, ma'am, are there any trials going on in India where if like any patients are there, they can approach or can
So
be referred?
India, to the best of my knowledge, no, at least I'm not aware of any. Clinical trials are going on for teriparatide. Uh, for these anti-sclerostin monoclonal antibody, the last that I had read about some preclinical studies and animal model studies. I'm not aware of any clinical trials as such. The mesenchymal stem cell therapy has been tried, even antenatal stem cell, fetal stem cell therapy has been tried. And there is a group in Singapore, if I'm not mistaken, where they're working on this, and they have shown good results with the antenatal stem cell therapy was done, and then the child was followed up postnatally and was there was a significant reduction in the fracture frequency.
Okay, ma'am. And ma'am, what would be like some pointers to the family members and caregivers of patients of osteogenesis imperfecta for like caring for the child at home, like some safety measures, other things, ma'am?
Yes. So yeah, that's a good point. So uh, especially in a young child where it's difficult to control their, they might want to move around. There's also a tendency to roll over and fall from the bed and fall onto the floor. So we need to tell the parents to be very careful, make sure that the child does not experience any kind of injury, trauma, even trivial trauma, as we know, can lead to fractures. So generally, what I tell parents is it's better to maybe have a room where you have like a soft mattress or something occupying most of the room, and then you make the child sleep on the mattress on the floor, a thick padded mattress, so that the child can roll around there on that, and also there's minimal risk of falling from that and injuring himself or herself. And once they start going to school, we usually tell the parents to make sure that they inform the teacher and the principal that the child has this issue, and therefore the child should not be pushed into any sort of strenuous exercise, any sort of contact sport, any sort of vigorous activity that can precipitate fractures. So all these measures, we do need to tell the parents about this care at home and also at school later. And of course, for adult individuals, again, once they, and also older children, once they are, able to understand for themselves what they need to do and should not be doing, we do tell them that they need to avoid all these things: strenuous activity, vigorous activity, contact sports, and things like that. Yeah.
Ma'am, there is a question from the Q&A section. What is the earliest age at which bisphosphonates started would help in preventing of fractures? Will the management outcome vary depending on the type of OI?
Yes. So ideally, the point of at the time of diagnosis itself in the moderate and severe forms of OI, you should start the bisphosphonate therapy, and early infantile period itself, like right from newborn period, first month of life itself, you can start IV bisphosphonate therapy. So there are studies which have shown that pamidronate is safe in infants. So zoledronic acid also, the safety has been established from about 6 months to 1 year onwards. So what we do is for a very young child, we initial maybe first one or two infusions or maybe up to 1 year of age, we give them IV pamidronate because there are good safety studies available. And usually after 1 year of age, we switch them over to zoledronic acid because safety studies are available from like 1 year onwards. And again, if they're doing well and with minimal fractures or no fractures at all, then after about 9 to 10 years of age, when they're able to take that oral alendronate whole, we switch them over to oral alendronate. So in terms of response, again, we know that as such, even without therapy, you have these four types: the mild forms, the moderate forms, the severe forms. So the response is usually for the milder forms, it may be, and especially in older individuals, oral alendronate usually suffices. For the severe ones, we have found that the ones who are started on therapy earlier on, like from very early childhood and on, do well with minimal deformity and good quality of life. But once they have already had multiple fractures and significant deformity, then you can start the bisphosphonate therapy to reduce the risk of further fractures. But by that point of time, if significant vertebral compression has already happened, significant bone deformity has already happened, their improvement in quality of life is not very good. And then there are some specific types of OI where they have seen that bisphosphonates don't really work. So OI type 6 for some reason, the bisphosphonates do not really work. I think that has something to do with the underlying molecular mechanisms. And just now I stated the example of type 5. At least I haven't read too many studies on this, but at least in our experience, the bisphosphonates worsened the callus formation and we had to discontinue.
And ma'am, there's another question by Dr. Deepa. A child found to have autosomal dominant osteogenesis imperfecta de novo, can there be another mutation expected in hotspots of these genes in the next baby? How to counsel in such cases?
All right. So the same hotspot variant happening de novo again in the next pregnancy, I would say is highly unlikely. But there is a reason for recurrence, and that is not really.
Ma'am, your voice is breaking, ma'am.
I think a network issue.
Yes, yes.
One of the parents. And due to that, there could be a recurrence in the next pregnancy. And
Ma'am,
because of
just
that,
we missed that. We missed this part of explanation, ma'am. The reason
oh,
for
okay, I'm sorry. Okay, I think again it was some net
network, I think
issues.
some little.
Yeah.
Yes. If
Right,
you
right.
can
So what
repeat.
I was saying, so what I was saying is, repeat occurrence of a de novo variant is highly unlikely. But for these apparently de novo variants, what happens is sometimes, not in all cases, only in a small proportion of cases, the variant which looks apparently de novo in the affected individual in the proband, may actually be there in one of the normal parents. If you test the DNA from the extracted from the blood of the parents, it will test negative only. But the variant may actually be present in a proportion of the gonadal cells of one of the parents. So because that is what we call germline mosaicism or gonadal mosaicism. And that can lead to potential recurrence in the next pregnancy. And therefore, due to this possibility of gonadal mosaicism, even for variants which look apparently de novo, we give an empiric risk of recurrence of around 1% to sometimes up to 3% for not only these autosomal dominant forms of OI, but for most other autosomal dominant disorders. And based on that, we tell the family that there is this empiric risk of up to maybe 1% to up to 3% maybe. And if they wish to opt for prenatal testing, they could do so. I mean, the choice is given to them.
Right, ma'am. So I think there are no further questions, ma'am. So I thank you for this insightful discussion, ma'am. And a special gratitude to the organizers also for creating this vital platform to raise the awareness about rare diseases, because these efforts are paving a way for compassion, research, and change. To the audience, I thank you for your patient listening. Okay, 1 second. There is one question by Dr. Dhanya Ravi. If you can type it in the Q&A section. If we have 5 minutes. Somebody just put up, yeah. I think if we can take one question, ma'am, before we
Sure, no
close.
problem. Yeah, no problem. And while we are waiting for the question, I would like to thank ORDI for this initiative and Mr. Prasanna in particular. And I think you're doing a great job of creating awareness about all these rare diseases, not only amongst clinicians, but also the general population. And it's really important that people come to know about these conditions. And as we've just seen, as in the case of OI, there are treatment options available. So it's not like once you have a diagnosis, you can't do anything at all. So it's important to know about all these conditions. And general pediatricians, general physicians, everyone needs to know about when to suspect these conditions, how to diagnose them, and what are the therapeutic options which are available. So yeah, thank you once again for this opportunity. And I'm really sorry for all the technical glitches that happened during the presentation.
No issues at all, ma'am. Ma'am, the question is, I am born with type 3 osteogenesis imperfecta, diagnosed with kidney stones. just trying to understand how to manage it as I have to take daily dose of calcium medicine.
Okay. But again, I would like to know whether the molecular confirmation has been done and what is the bone mineral density status. When was the last DEXA scan done? And how many fractures have happened so far? And does it really fall under type 3 category? Because type 3 is the severe deforming type, and also the age and what treatment has been initiated to date. What is the extent of deformity? So, without that background information, I can't really give a very, proper sort of answer to this question. But on the whole, yes, bisphosphonate therapies can be started. And of course, orthopedic support, as I had mentioned. But I would really like all this background information to give a more meaningful answer.
This question was asked by Ms. Dhanya Ravi. She is herself a OI warrior. So,
Yeah. So
yes,
I understood that. But if she can probably give
yes.
the
So she's saying that
additional
she
details about all these other aspects, then we can probably help her better guide the treatment in a better manner.
Yes, ma'am. Yes, ma'am. So she is a President Award winner as well.
Okay, that's great. Great. Very nice. Congratulations, Danya.
Wonderful. And it's wonderful to have participation from such inspiring people.
Absolutely. Yes.
It's great. I mean, I think this platform benefits even the students who are studying, and they get to hear from such senior doctors, and also the patients who can interact with and ask their questions. So that's really great.
So